Right, so we're going to get started. People may or may not join in, and it's a small group, so by all means raise your hand and I will look at the question panel and take it. But I want to welcome you this afternoon to our presentation. I always like to start at the beginning by defining terms so that we're all on the same page and understanding what epilepsy is and what seizures are. So the first section is going to focus on epilepsy. And as you can see on this slide, that it is a neurological condition characterized by its main symptom, which is seizures, and that it's not a rare condition. There are rare forms of epilepsy. However, there's estimated to be over 60 million people throughout the world living with the condition. There are very rare forms of the condition, but how epilepsy presents depends on the type of seizures they have and the frequency and severity of those seizures. I want to be very clear that some people refer to epilepsy as a seizure disorder, and I want you to be clear that the two terms are the same. Even though if you visit your local pharmacy to pick up a medical alert brochure to order a necklace or a bracelet or a shoe tag identifying someone with the medical condition, alphabetically you'll see epilepsy, and then further down the list you will see seizure disorder. Please be clear, they are referring to the same condition. What you're seeing is concrete evidence of the stigma that is attached to epilepsy, that some people just prefer to call it a seizure disorder instead. But they both refer to something where two or more seizures not caused by an underlying medical condition or what doctors refer to as provoked seizures, all right? Every once in a while, we'll come across someone who has a single seizure, but when the neurologist looks at their EEG or their MRI, they see such a strong indication that there's likely to be more seizures in the future, they'll make the diagnosis after only a single seizure. But most often you'll find, particularly with children, they wait until there's two or more seizures in the history before making the diagnosis. So, which leads us to, if I have a seizure, do I have epilepsy? And the answer to this question is, well, no, not necessarily. Seizures happen for lots of reasons, and this slide shows you some of the more common examples. So children can suffer, infants and toddlers can spike a high fever and have a febrile convulsion, or 5,000 seizures every year are directly attributed to alcoholism or withdrawal from drugs. So drug addicts can have seizures. But there's lots of reasons. People suffer from infections that cause them. Some lesser known examples, sorry, my slides are not cooperating. There we go. I think we went back too much. But epilepsy doesn't discriminate either. It affects people equally. The age of onset covers the lifespan. It doesn't matter what ethnic background, what race you are, what socioeconomic group you belong to. Epilepsy does not discriminate. Now, we do see the largest numbers of newly diagnosed in the very young and the very old. So if you think of it as the under 10 population and the over 60 population, but there are forms of epilepsy that develop at any age. And then there's some certain types of epilepsy syndromes that are common to occur at adolescence. So there's another little bump up for that age group to develop the condition. Just to touch upon the demographics so that you realize it's not a rare condition, even though under the epilepsy umbrella, there's more than 40 different conditions, and that some of those are quite rare forms of epilepsy. But epilepsy as a whole is the fourth most common neurological condition. So the number one most common is migraine, the second is stroke, the third is Alzheimer's disease, and then the fourth is epilepsy. And as you can see in the last bullet, it's more common than these three neurological conditions combined. So when we talk about 3.4 million Americans living with active epilepsy, the neurologists define that as someone who is under a treatment to control their seizures or someone who's had a seizure in the past year. They're considered to have active epilepsy. Now, under that umbrella of epilepsy, there are some forms of epilepsy that are outgrown, or they resolve themselves just as abruptly as they showed up for a person. So that's how we have this higher number where we say there's over 5 million Americans who have had a history of epilepsy. And again, because there are so many different forms that arrive at different points along the lifespan, the incidence is actually 1 in 26 people will be diagnosed with a seizure disorder. And referring back to those seizures due to underlying medical conditions, seizures are not rare at all. I personally subjectively believe that seizure first aid should be commonly learned, just like people learn first aid and CPR, because 1 in 10 people throughout the world will experience a convulsive seizure at some point in their life. That's pretty common. Now, we do recognize that living with the condition presents its own unique challenges. And one of those things is that there are forms of seizures that are so subtle that there's a delayed recognition by the individual or by their family of recognition of these episodes being seizures. So that's the first hurdle. Then the second hurdle we worry about is inadequate access to treatment. So we here in the New England affiliate, we represent 4 very diverse states: Massachusetts, Rhode Island, New Hampshire, and Maine. And once you leave a major metropolitan area, you don't have access to major medical centers. I mean, here in the Boston area, we have 5 medical centers that not only have neurology departments, they are accredited epilepsy centers within those neurology departments. That's not the case once you get out to Western Massachusetts, or you get up to the northern reaches of New Hampshire and Maine. I mean, it's really, New Hampshire's big epilepsy center is actually on the Vermont border at Dartmouth-Hitchcock in Lebanon, New Hampshire. And for Maine, their epilepsy center is in a neurology practice affiliated with Maine Medical Center. They're located in southern Maine in Scarborough. And in Rhode Island, Providence, Rhode Island Hospital is the only location. So once people are outside those metropolitan areas, we worry about their access to appropriate treatment. Oftentimes, people in rural areas are getting diagnosed and treated by either a primary care physician or a private practice neurologist if one is in their area. Another challenge is that there's a high correlation between mental health and epilepsy. Specifically, we see a high incidence of anxiety and depression that occurs with the condition. We also see the challenge of cognitive impairment, and this may be due to years of uncontrolled seizures, or it may be a side effect of the medication being used to treat those seizures. But we worry about that because it has a grave impact on people's lives. And then because of the intrusive nature of seizures, they're abrupt and intrusive, people tend to self-isolate. You know, they limit their social activities because they're concerned what's going to happen if I have a seizure in public. And we see overall a lower socioeconomic status for this population. There was a study done probably about 15 years ago now, and it was a very small study. I wish it had been repeated in a larger population group, but this one study found a 54% unemployment rate for adults living with epilepsy. And it was a combined underemployment or unemployment rate, and that's very disturbing. So this is one of many reasons why we're so eager to bring seizures under control so that the prognosis will be better. We worry about the stress that occurs on the caregiver and the family, the support system for the adult or child living with epilepsy. There's that, I call it the parental vigilance. When your child develops epilepsy, you're on hyper alert all the time. You hear a loud noise and you're like, what's that? And you're checking on the person. And we know that this stress over time takes a toll on the caregiver, so we need to be sensitive and aware of that and provide support strategies to help them through this. And then, of course, we still have to deal with most people do know very little about epilepsy, and sometimes what they do know is not accurate, and that there is still a stigma attached to epilepsy. So I took a call yesterday where someone complained that she had a nurse come into her home who was from a culture that believes epilepsy has to do with evil, that it's evil or it signifies possession, and that this person who's a professional, supposed to be a nurse to provide home care, came in and said, oh, I can't deal with this, I can't handle this, and left. And then this person called us and said, wait a minute, can they do that? So believe me, that stigma still exists today. Okay, so that's my brief overview of epilepsy. Let me check quickly to see if there's a hand raised for questions. I don't see one, so I will move on into seizures, seizure basics. All right, so the seizure itself is just an abnormal electrical disturbance in the brain that affects one of these four things: movement, sensation, awareness, or behavior. And depending on the type of seizure, it might affect 1, 2, 3, or all four of these things, just depending on the type that occurs. So what can it look like? Well, it can be as something like a person just pausing in their activities and just staring off into space. Maybe they might have a small muscle twitch in their face or their hand or their arm or their leg, one side of the body or both sides. They may have difficulty speaking. They may appear confused. There may be some automatic mouth or hand movements that look like chewing or licking of their lips or smacking of their lips. They could be wringing their hands or picking at their clothing. They could get up and wander around during some forms of seizures, or they may appear to be unsteady and unbalanced. And then there's the ones that most of us, when we hear the word seizure, think of, where a person loses consciousness, they fall to the floor, they stiffen and shake, they're completely unaware of what's going on around them. And then there are even other forms of seizures that really don't have any outward signs. They're completely internalized, where the person is experiencing a sensation or a funny taste or a funny smell or an auditory hallucination, but nobody else is experiencing it. And unless they share that information with us, we don't know that they're having it. So the way the seizure looks depends on the type of seizure the person is experiencing, and that has to do with how much of the brain and where in the brain the seizure is occurring. Now, a reassuring thing, I think it's reassuring, I find it reassuring for epilepsy programs, is that once I get to know a person and I learn about their seizures, either by witnessing them myself or by asking questions of the person to tell me, to share with me that information, that while seizures can look, the same seizure can have a different length and a different severity and a slightly different presentation from person to person. Once you get to know that individual, their seizures become predictable because they're typically consistent from time to time. Now, that's not to say people can't develop new forms of seizures depending on the type of epilepsy they have. They can, but you don't see big variances between individual episodes. It's usually over time you're saying, that's something new. Let me call the doctor and see what's going on. Because from episode to episode, you'll typically see the same mannerisms or symptoms. So how do we get to that diagnosis of epilepsy? Well, the key data is provided by the people who witnessed and observed the episodes that led to the person being brought into a neurologist. So really don't take for granted how important that anecdotal evidence is. It's very important. So, and then the next thing is, once they say they want to go looking at a recording of the brain activity, that's when they'll do an electroencephalogram, where the leads are put on the surface of the scalp with this funny glue, and a recording is made typically for an hour for an outpatient procedure. Many people, if they're really trying to pinpoint things, might be brought in for a longer period, what we call long-term monitoring and video monitoring, where they're brought into the hospital and placed in a room where they're videotaped 24 hours with the leads on their head so that the outward signs can be matched up with what they're seeing on the EEG. And then other times they might do an ambulatory EEG, because oftentimes in the hospital, that's an artificial environment. And in spite of the many things they do to try and make seizures occur during this testing, you wouldn't believe how many times people don't have seizures there. So they may try an ambulatory one to get them in their own routine where they wear the electrodes home and for a period of time. And it might be 2 days, 4 days, it just depends. I have known people that have had to go into the hospital for as long as a week or two for some long-term monitoring, but more typical is anywhere from 2 to 4 days. We also use an MRI to get a picture of the brain to see if there's some sort of structural reason why the seizures are occurring. You know, they're looking for, God forbid, a brain tumor, or they're looking for scar tissue or lesions or some sort of malformation. But neurologists are really concerned about getting an accurate diagnosis for epilepsy, because the course of treatment really depends on that accurate diagnosis. So these are the list of healthcare providers who can help to diagnose epilepsy. So oftentimes it's the primary care physician or pediatrician who'll make the referral to a neurologist, or the emergency room physician who'll make a referral to a neurologist. I remember when my daughter had her first tonic-clonic seizure at a birthday party at an arcade, and the ER physician called down 2 consultations. One was a cardiac consultation and one was a neurological consultation. And the cardiac came back clean and the neurological one did not. So we were sent for further specialty care. We here at the Epilepsy Foundation strongly advocate that if your seizures or your loved one's seizures are not brought under control in a reasonable amount of time, and that reasonable amount of time could be, 3 to 6 months, a year at the outside, that perhaps if you're only seeing a primary care physician or a private practice neurologist, that you may request, and if your insurance allows it, a referral to an epileptologist. And you're really only going to find an epileptologist at the large main medical centers that have an accredited epilepsy center. So that does present a little bit of a burden for travel, but I want you to know that we here at the Epilepsy Foundation New England and our national organization recognize that people have to travel a distance for this specialized treatment. So please call us and let us know how we can plug you into these travel assistance programs. They do exist, so you want to avail themselves of you. Typically, it has to do if you have to travel more than 50 miles to get care by an epileptologist. This is a really important slide because epilepsy is a spectrum disorder. I think we're all accustomed to thinking of autism as a spectrum disorder, but epilepsy is too. So approximately half of the people, and numbers vary. Some neurologists that I talk to think the number is less than half. Some think, I had one neurologist say it's as high as 80%. My perspective might be a little skewed, but I'm skeptical that it's that high, that people have really good control of their seizures with medication, and we consider them uncomplicated. They pretty much resume all their normal activities. Children should not be restricted from participating in school activities, sports, anything, field trips, none of that stuff. And certainly adults are even cleared to drive. Now, the driving laws do vary state by state. In Massachusetts, it does state that you must be seizure-free for 6 months or with doctor's recommendation. For New Hampshire, it's 12 months seizure-free. For Maine, it's 3 months seizure-free or doctor's recommendation. And in Rhode Island, it's 18 months seizure-free. Now, as we don't have control of seizures and we move down to the opposite end of the spectrum, this is where epilepsy can become quite disabling. The frequent seizures are intrusive. They cause their own problems. The side effects of the treatment options, typically people are on more than one anti-seizure medication at this point, and we really worry about the long-term impact that these recurring seizures have on the brain. As a mom myself, I can remember wondering where on earth did this come from, because there was no indication that our daughter was going to develop epilepsy. She didn't even have febrile convulsions as an infant or toddler, and yet her cousins, my sister's children, my niece and nephew, both suffered febrile convulsions. Thankfully, they did not grow up and develop epilepsy, but my daughter did. Well, imagine my surprise when I learned this fact in front of you on the slide. Most of the people diagnosed with epilepsy, it just showed up. They don't know where it came from. The remaining 30%, however, that do have symptomatic epilepsy can trace the causes back to things that are listed on this slide. So the most common ones would be head trauma, stroke, brain tumor, or brain infection. And if you're wondering what a brain infection would be, it would be things like meningitis or encephalitis, those conditions. But then there's other lesser known causes. These aren't as common, but for metabolic disturbances, I know several people children specifically, who have mitochondrial disease, and that was the underlying cause of their epilepsy. Or perhaps they have one of the genetic mutations, such as Dravet syndrome or Dozier syndrome, where they have a genetic mutation in the SCN1A gene or one of those. There's autoimmune conditions like lupus erythematosus. That's a disease where it causes the person they actually attack their own organs, and it tends to focus on different organs in different people. So I met a person whose lupus presented by attacking the skin, which is our largest organ, and another person who had kidney disease due to their lupus. Well, I also know a young woman who has seizures due to her lupus because it affects her brain. And then, of course, there's things like, sorry, I just had a total lapse in memory, congenital conditions or birth defects, things like that, any sort of structural abnormalities of the brain. And as if, the opioid crisis isn't in the news enough, we're really concerned because maternal drug use greatly increases the risk of a child born to that mom developing a seizure disorder. Okay, so we can loosely group those causes by age. So what you're more likely to see in infants and young children are the genetic disorders, the birth defects, and the metabolic disturbances. What you're more likely to see in the young adult population is head injuries and tumors, and then more common in older adults is stroke. Now, this is not an absolute list, because I happen to know 2 individuals who developed epilepsy as children because they had intrauterine strokes before they were even born. And another young woman at 12 who developed it because when she was a toddler, she had cancer, and the radiation treatments caused her to have a stroke. And then later on, she developed epilepsy from that. So this is not to be taken as a verbatim end-all be-all. This is just loosely grouping what you're more likely to see. Okay, so moving on quickly to seizure types. Neurologists group seizures according to whether or not the seizure begins in one part of the brain or it occurs in both hemispheres simultaneously. So they're looking at how and where they begin in the brain. And this is really important to the neurologist for treatment choices. So when you are told that your loved one or you have a generalized onset seizure disorder, that means that your seizures are always occurring in both hemispheres of the brain. And if you have a focal onset, then it's only happening in one hemisphere. So it could be right frontal lobe, or left temporal lobe, or right parietal lobe, etc. And then that third onset, unknown onset, is when they just don't have enough information to pinpoint it yet. So they group everybody there until they have more information. So here you see an example of a generalized seizure where it involves both hemispheres of the brain. So up here you see a little EEG scan. So here's the normal brain waves during sleep, and then all of a sudden everything goes crazy. And very loosely, you can split these waves in half. One half represents the left side, and one half represents the right side of the brain. And as you can see, that activity is happening throughout the brain. Now, these seizures can be just a second or two, or they can be 10 or 15 seconds, or they can be 1 to 3 minutes. And the symptoms can include just a blank staring or a pause in activity, a loss of consciousness, any sort of stiffening or jerking that you see. There can be incontinence involved. It just depends on the type of seizure. So here we have a list of the generalized seizures. So absence seizures are what we used to previously call petit mal or petit mal. Tonic seizures is when someone gets rigid like a tree, and they'll typically fall over like a tree. Clonic seizures are when, now if it's generalized, you're going to see the jerking or shaking on both sides of the body. Myoclonic seizures, those are large muscle jerks. So if you've ever had your foot give that funny twitch as you're falling asleep at night, that's similar to what a myoclonic seizure is like, but typically the people who have these seizures will have them in their upper body. So one or both hands might jerk, or their whole upper body might shrug suddenly. That's what those would look like. Atonic seizures are the opposite. So instead of stiffening up rigid like a board, they lose all muscle tone at once. Then they become like a rag doll, but they tend to fall with force. So kids who have atonic seizures, we commonly call them drop seizures, will typically wear some form of head protection or a helmet with a faceplate because the potential for injury is quite significant. And then we have the tonic-clonic seizure. So if you see the notation in your doctor's notes, GTC, that means generalized tonic-clonic seizure. That's what we used to call the grand mal seizures. These are the big scary events, and they are scary to witness. They really are. But once you learn and understand what the typical progression is for them and how to respond with them, I can't lie to you and say I like them any better. I still get that adrenaline rush, but I do know how to respond now. So that helps a lot. Okay, moving into the focal side, here on this MRI picture, we can see in this little light area, this is considered a focal area for the seizures in this person. So it's only happening on one side of the brain, all right? And what we see, the symptoms of that seizure depend on what part of the brain they are. And this is actually the more common seizure. 60% of the people, and I've actually heard it said as high as 75% of the people living with epilepsy, their primary seizure form is focal, not generalized. So under the focal type, what we see here are ones that have motor activity associated with them. Yes, that does mean people can get up and move around during their seizures, but they're typically not even aware of their surroundings during it. Or they can have those sensory focal seizures where I told you people get a funny taste, or they smell something funny, or they have a change in their visual perception, or they have an auditory hallucination. And then there are those people that have autonomic focal seizures where all of a sudden their heart rate or their breathing changes and gets alarming to them, or maybe perhaps they start sweating profusely. These are autonomic body responses that occur during their seizures just because that particular area of the brain is being stimulated by that abnormal electrical activity. And then the even harder ones to recognize as seizures are the ones that have psychological symptoms for their focal seizures, where it resembles a panic attack or an anxiety attack, or perhaps they're expressing, some form of deja vu or jamais vu. And then here's that catch-all. I'm not going to spend too much time here because time's moving right along. Let me just check in here and see if there are any questions at this point. I do not see a hand raised, and I do not see any questions in the panel either. Okay. All right, moving on. All right, so our treatment options, we always look at medications first. And you know what? That's actually a misnomer to call it anticonvulsant medications, because we have medications that specifically work on focal seizures and could potentially make generalized tonic-clonic seizures worse and vice versa. So this really should say, I have to change this slide to say anti-seizure medications. And in the United States, there's over 30 that are now FDA approved for use. I'm not going to spend too much time on this. I'm just going to basically name it. If you're interested in learning more about treatments, then I encourage you to sign up for the next month's webinar in May, Epilepsy 102, where I'll go into more details about these treatment options. But medication is typically the first thing we try. Then there's a couple of devices on the market, a vagus nerve stimulator and a responsive neurostimulator. There are dietary therapies that we use very successfully, I might add, to treat certain forms of epilepsy. And when someone is drug resistant, that's an actual diagnosis that someone has drug resistant epilepsy. Oftentimes, these are the places that the neurologist will look to as a viable treatment option. And then if the person is a candidate, because not everybody is, they'll look at some surgical interventions, such as a laser ablation, where they're using a laser to go in and scrape a lesion or some scar tissue or whatever's thought. Or they might actually do a resection, a surgical resection. And there's some pretty extensive surgical options that you're thinking, oh my God, who would do that? But if your child or your adult in your life was having hundreds of seizures a day, then yeah, you might be looking at that, drastic surgical. But as I said, I'll go into more detail at next month's webinar. So what's our prognosis for epilepsy? Well, it depends on the underlying cause. So we find that the generalized idiopathic epilepsies, and what I mean by that is, remember I said 70% of the people don't know the cause of their epilepsy. Those typically respond, forms of those will typically respond to medications pretty reasonably well. But again, it also depends on the seizure type. We find it that the people that have symptomatic epilepsy or epilepsy due to an underlying genetic cause, like that genetic mutation, those are the tough ones that we have a hard time treating. So as you can see on this slide, it's telling you that when we see that good response, it's predictive of our long-term outlook for it. And there are those lucky people. This slide says approximately half. Again, my perception working for the Epilepsy Foundation is somewhat skewed because I typically hear from the people who aren't doing well with their epilepsy. But I do know those lucky few who are able to discontinue their medication because they've been so well controlled and their EEG, all the testing is looking good. There's no underlying physical cause that's thought to heighten the risk, and they're able to discontinue their medication. And the range is large, from 2 to 5 years of being seizure-free, because it really depends on the type of epilepsy they have and what their history has been. But we can pretty globally say that most children who are diagnosed with Rolandic epilepsy, there's a very, very high number of those kids that are lucky enough to outgrow it. It disappears by the time they enter adolescence. So why do people have breakthrough seizures? Well, we're human beings, taking those meds as prescribed, that's not always the easiest thing for people to do. And as the mom of a former teenager, I'll vouch that, missed medication is that #1 reason. Parents of children tend to be very vigilant about how their kids get it. But if there's economic factors in play where they just can't afford the medication, adults and even families will, perhaps try to stretch out the doses. And that's never a good idea with epilepsy meds. They need to be taken as prescribed. So if you're on a twice-a-day dosing regimen, it needs to be as close to 12 hours apart as you can make it. And we often, for EEG testing, will ask that the individual be deprived of sleep. So I remember sending my teenage daughter to bed at midnight and waking her up at 4 a.m. so that she was sleep deprived, and it worked. She did have seizures, just not during the EEG. She had it with me at home. Anyway, but we also want to be extra vigilant when somebody's ill or when they're having a fever. So we definitely want to pay attention to that as well. So, and then anytime you're going through a medication change or an adjustment in the dose, you just want to be a little extra careful in your activities because those are prime times to have breakthrough seizures. And then for teenagers and adults, we do worry about how they use alcohol and recreational drugs. Not only do they interfere with their epilepsy medications, but in the case of alcohol, there's a rebound effect as the alcohol is leaving their system, as they're sobering up, where it really raises the risk to have seizures then. So it's not just when they're drinking, it's 24 to 48 hours later that we worry about that. All right, so this is actually a redundant slide, but these are possible seizure triggers. I do want to point out that while commonly everybody says, oh, strobe lights, flashing lights for the person with epilepsy, and we do use strobe lights during EEG testing, really only about 3% of the people living with epilepsy are truly photosensitive. However, if they are photosensitive, sunlight dappling through the trees or through mini blinds, it has to do with that patterning effect, which is what triggers the seizures. But you'll see again that we talk about stress and anxiety. Again, this is something I'll do in more detail on Epilepsy 102. This is the difficult conversation. Nobody wants to think about mortality in epilepsy, but we really have to touch upon it because it exists. And for the individuals and families that it happens to, it's truly tragic. So my goal here is not to frighten you, it's to make you aware. So think of it like SIDS, sudden infant death syndrome, sudden unexpected death in epilepsy. It happens, and you see the incidents written here, but we do know that the greatest risk factors are for those with uncontrolled seizures, specifically generalized tonic-clonic seizures, okay? And you see how the rise goes from 1 in 1,000 in adults to 18 in every 1,000 for people who have more than 3 generalized tonic-clonic seizures per year. And we don't know the exact cause, but researchers have been investigating the role that abnormal breathing patterns, abnormal heart rhythms, they're trying to determine if there's a genetic factor involved, and they're specifically looking at the brainstem region because when people's seizures resolve on their own, their brainstem, which is where all our autonomic things, our heart rate, our breathing is all controlled from back there, it reboots or turns itself back on by itself. Well, we're looking at people who have an unusually long recovery period for their seizures, what the doctors call a postictal period. And that's why they're looking at that specific region. So what do we do to reduce our risk? Again, we here at the Epilepsy Foundation really encourage you to get a referral to an epilepsy center. If you're still having seizures, this is key to do. And we encourage you to be compliant with your medication. Take it reliably. Use tools. Use a watch that'll beep or remind you, or put an alarm on your cell phone or on your smartphone. There are things to do so that you don't forget your doses. And keep your medical appointments. Even if your seizures are well controlled, there are other things that your neurologist needs to look at because you're using these medications that, yes, they may be working to control your seizure, but we have to keep an eye on other bodily processes to keep you healthy. All right. And then we also want to look, there's a lot of seizure mimics out there. So if seizures aren't well controlled, ask your doctor if you should have a cardiac workup because there are some cardiac conditions that actually mimic seizures. So we want to look at all options. All right. And then certainly if we need some sort of monitoring or supervision at night, talk to us here at the Epilepsy Foundation. There are certain devices and that are out there that can help parents monitor their kids during the night, or an adult could wear a watch that would alert a caregiver that they're having a seizure, things like that. And then, of course, all of us should be taking care of our health by eating well, sleeping well, and exercising regularly, and minimizing stress. Okay, so I can see that my time has elapsed. Let me check in and see if, okay. All right, moving into seizure first aid really quickly. This is the last section of today's lecture, and it's really simple. Seizure first aid is actually quite simple. So for the majority of people diagnosed with epilepsy, seizures do come to an end naturally on their own within seconds or a few minutes. Actually, the majority of tonic-clonic seizures fall in the 1 to 3 minute range. It feels like a lot longer. And people with focal seizures, again, the majority of them fall in that 1 to 3 minute range, but our safety time frame is 5 minutes or less. So specifically, if someone has a tonic-clonic seizure, they fall into the floor, we want to make sure the area around them is safe. So move objects out of the way that their legs and arms might be hitting. Place something soft under their head. It can even be your hand if there's nothing close at hand. And you're going to roll them on their side so that all that excess saliva, when you hear people say, oh, they foam at the mouth, that's actually due to all the excess saliva that's produced during a tonic-clonic seizure mixed with the air, creating those bubbles. So you turn them to their side so the saliva will drain out. It aids their breathing. The tongue falls to the side of the mouth, and their airway is kept open. For the focal seizures, that second last bullet is referring to people who have a wandering symptom where they actually are getting up and moving around, but they're not aware of their surroundings. So you want to stay with them and then just gently steer them. You don't want to grab them. I call it shepherding, just a loose guiding arm around their back, very like barely touching them, all right, to just get them away from danger. Because people who are having these motor focal seizures, potentially, could they wander into traffic if they're out on the street? Yes. If they're at the top of a flight of stairs, I've seen people walk down the stairs and I'm like, geez, I don't know how you did that. But then there's other people that I'd be concerned that they would fall down those stairs. So you just want to keep them safe. Time the seizure, because how long the seizure lasts is very important, not just from a first aid point of view, but it gives the neurologist really key information as to how severe this person's seizures are. So for example, I'm knocking on wood here as I sit here in my office. My daughter has never had a generalized tonic-clonic seizure that's been over 2 minutes, ever. And we're talking 23 years of living with epilepsy. So timing the seizure is key, because if I see her have a seizure that goes longer than 2 minutes, I am going to be concerned. Something's going on. So you want to get to know that. And people will typically have their own little range of how long their seizures last. And when we stay with them, there's going to be a confusion period after. So when we say the seizure ends, we're not talking about the person being back to baseline and able to talk and interact. We're just saying that the actual symptoms of that seizure ended. So for a tonic-clonic, they're no longer stiffening and jerking. Typically, they'll be sleeping for some period of time after the seizure. And when they do awaken, they're typically confused and they might have some difficulty speaking for some period of time afterwards. And this varies from person to person. Some people are able to talk in 5 or 10 minutes. I had one person at an art program who couldn't say a word until 30 minutes had gone by. And then we never restrain the person. We never put anything in their mouth, ever. So the 5-minute window is what we're comfortable with. We know that the outcome is good if a seizure resolves itself on its own in less than 5 minutes, 5 minutes or less. All right. Certainly if they injured themselves in the fall, that's going to warrant a trip to the ER. If it's a first-time seizure, absolutely. If they have trouble waking up some period of time after the seizure, or their breathing hasn't resumed normal patterning, okay? And then we always worry if seizures come too close together. We call these clusters. And the person isn't allowed to have a full recovery because they keep having multiple seizures. So we need to get into the hospital and get some eyes on this person to see what's going on. Now, not epilepsy, but very dangerous. We worry if a woman who is pregnant has a seizure. That's dangerous for the unborn child. Anybody who has diabetes or a heart condition, remember what I said, their blood sugar could be out of whack. That's a provoked seizure or a seizure due to an underlying medical condition. These people need to be seen right away. We're not timing it. We're not waiting the 5 minutes. We're calling right away when somebody with diabetes or a history of cardiac problems or a pregnant woman has it. And then just because of the danger of aspirating water into the lungs, whenever a seizure happens around water, we want to get them checked out to make sure that they're not going to develop pneumonia, 4 or 5 days later. There are some rescue medications. I don't have time to go into these, but I do go into how to administer these and use these during Epilepsy 102. One of them is a rectal suppository that you see here. Another one is a nasal spray, midazolam nasal spray. And then there's some pill forms. There's sublingual and subbuccal forms of benzos like Ativan or clonazepam, those things. So those I'll go into more detail next time. I will also touch upon the impact on learning behavior. This is really important for children who are still in school, but it's also important for adults who are trying to function at work, to talk about memory problems and what can happen, the side effects of medications, and ways that we want to help bolster the person with epilepsy so that they're not feeling embarrassed by their seizures. Okay, that brings us to our contact slide. So I see, and I apologize, I went 16 minutes over our allotted time. Let me check in very briefly to see if you have any questions. I do not see questions or a hand raised. I want to encourage you, if you have any trouble downloading any of the handouts, let me know and I'll email them to you directly. But I want to thank you for taking the time with me on this webinar today, and I hope you have a great afternoon. Thank you. The webinar is over now.